Good evening, everyone. This is Dr. Pratik Joshi again, and after quite a long hiatus, I am back with a new series of lectures, which is Orthopedic Radiology for Undergraduate Students. Now, this particular lecture is the introduction. It is the first part of a three-part lecture series where we will try to cover the length and breadth of the orthopedic radiology which is required at an MBBS level. So, without any further ado, allow me to move on to the session objectives. So, at the end of this session, you should be able to correctly read an orthopedic radiograph using the 3-sentence format which we will develop through the course of this lecture. Moving on, we should also be able to accurately relay some common radiographic findings which are expected at a graduate level. Followed by that, in some cases where the diagnosis of an X-ray is not obvious, it may be necessary to provide differential diagnoses which we will provide with this format. So this is a format which we will create in which you should report radiographs in the exam as well as in clinical practice in order to minimize omissions and errors. I will also try to cover a few noteworthy points for competitive examinations in the upcoming sessions, and all of this of course within a time frame given your limited time that can be given to this kind of a topic. So, reporting a radiograph runs on a few basic principles, and the few basic principles are as below. The first one is that the first sentence should identify the radiograph, and this should be a short, crisp and scientific sentence to let the examiner know that you are building up towards making a good reporting and that you know your basics. Remember, the first impressions are the last impressions, and this first sentence will set the stage for the rest of the radiology which you will report. Followed by that, the second sentence should note the obvious normal and abnormal findings, and the third sentence should provide some amount of detail and then go into a provisional or a differential diagnosis depending on what you have in front of you. A bonus is if you are able to provide a classification for the condition visible. However, please remember that not all conditions may be classified at an undergraduate level, and therefore this is not a pass-fail criteria, but this is a bonus marking criterion. So, let us start on the 3-sentence format where the first sentence is the introduction. The introduction first talks about the anatomical localization, which means you will talk about which joint is being pictured in the X-ray given to you. In this case, it is the elbow joint. This is the first point to be covered. The second point is the view or the projection in which the X-ray has been shot. That is in this case a lateral projection. Then the 3 general characteristics which you are expected to comment on are the centralization, the rotation and the exposure. So the centralization refers to the centralization of the X-ray, which means that whatever is supposed to be roughly along the midline in the body should be on the midline of the X-ray. So on a general principle, if the X-ray is focusing on the elbow joint and the proximal forearm, then the elbow joint should be towards the center of this X-ray, which we can see. So this is a well centralized X-ray. Moving on to the rotation, the X-ray should ideally be in neutral rotation, which means that either anteroposterior or lateral, the direction of the X-ray beam should be directly perpendicular. So in case of an anteroposterior view, the two similar or two congruent structures on either side of the midline should be equidistant from each other. In the case of a lateral view, the similar two congruent structures should overlap each other. For example, if we see in this lateral X-ray, the two condyles of the humerus are overlapping each other and there is no shadow which we can see, and therefore not only is this a well centralized X-ray, this is also a neutrally rotated X-ray. And with that we come to the last point, which is the exposure. Now exposure again is something which is a relative criterion to talk about at an undergraduate level. On a general principle, if the bone and the soft tissue shadow are clearly demarkable, then you can go ahead and say that the exposure is adequate. So, the first sentence for this particular X-ray would be that this is an X-ray of the elbow joint in the lateral projection with good centralization, neutral rotation and adequate exposure, showing the distal humerus and the proximal radius and proximal ulna. This was your first sentence of your X-ray. Moving on, let us take a look at the second sentence, which provides a broad overview of the bones that you are looking at. So you can make a comment on the skeletal maturity. In this case, all the epiphyses appear fused, and therefore this is a X-ray of an adult or a mature skeleton. Followed by that, you can also make a comment on the joint position, where the elbow appears flexed to 90 degrees. Then you can talk about articular congruity. Here, as you can see, the humero-ulnar articulation seems to be maintained. And lastly, you will name any gross dislocation, fracture or subluxation which is visible. So you can see a fracture in the proximal 1/3 of the ulnar diaphysis, along with a dislocation of the radial head towards the anterior side. So, your second line describing this X-ray will be that the X-ray shows bones of a mature skeleton with the elbow joint in 90 degrees of flexion. The humero-ulnar congruity is maintained. However, I can see a fracture of the ulnar diaphysis in the proximal 1/3, along with a dislocation of the head of the radius. And in your third and final line is where you will talk in detail about what you can see. So you will talk about the fracture pattern, which in this case is a short oblique fracture. You can talk about the orientation of the fracture line. You can also talk about whether the fracture is in one piece or in multiple. Here there are just two pieces, and therefore this is a simple fracture. Then if the fracture is displaced, you can talk about the direction of the displacement, which in this case is ventral or volar. Similarly, the dislocation of the radial head is also anterior, and therefore you will be able to provide a final diagnosis of this particular X-ray, which is your fracture of the proximal 1/3 of the ulnar diaphysis with a volar angulation and an anterior dislocation of the head of the radius. This is nothing but what we call as a Monteggia fracture. And if you are confident about the classification, you would know that this is a Bado type 1 fracture of the Monteggia variant. So, just to revise, let me talk about this X-ray using our 3-line format. The given X-ray shows the elbow joint in lateral position with good centralization, neutral rotation and adequate exposure. I can see that the joint is showing the bones of a skeletally mature individual. The humero-ulnar articulation appears to be well maintained. However, I can see a fracture of the proximal shaft of the ulna, along with a dislocation of the head of the radius. The ulnar fracture is a simple fracture with a direction which is approximately a short oblique kind of an orientation. The fracture is displaced with a volar angulation, and the head of the radius is dislocated anteriorly. Therefore, my diagnosis is a Monteggia type 1 fracture dislocation. The name of the classification is Bado classification. So, the general principles about X-ray reading, of course, we will get into these in detail in the subsequent sessions. The first one is to watch your watch, which means that all of this has to run on a time frame. The X-ray table in orthopedics is something which is not allotted a lot of time, and therefore it is like a hot seat scenario where you have a short amount of time to gain those many marks. In case you are not sure of a particular classification or a particular intricate detail, always remember that omission is better than wrongful commission. Then, in every X-ray, there will be a few debatable issues such as osteopenia, the size and shape of the soft tissue shadow, and the degree of degeneration. These are kind of things which have a lot of intra-observer variation, and therefore it is wise not to get into a debate about all of these things in the limited time that you have. That being said, once you have provided the diagnosis, the next question is going to be on the management, and therefore you must have a rough idea of management such as open reduction internal fixation, close reduction with manipulation and splinting, or others. So, I hope you liked this introductory session on orthopedic radiology. In the upcoming sessions, we will be dealing with traumatology, cold orthopedics, pediatric orthopedics, and a little bit of orthopedic oncology from the radiology point of view. So, I hope you like this session, and please do not hesitate to get in touch for any further help or guidance. Thank you so much.